Hi Ellen, I'm Jessica Fontaine, and I'm going to tell you a little bit about our patient. So this patient is a 17-year-old male who presented with lateral ankle pain and swelling following a twisting of his right ankle 2 days ago while playing in a soccer game. He mentioned that it occurred upon landing after he went up for a header. The patient has a history of multiple ankle sprains to his right ankle. His current pain is an 8 out of 10 on the NPRS scale. He is a high school student who plays soccer and lacrosse competitively and has recently signed a full scholarship to play soccer at the University of Virginia in the coming fall. No surgery or PT was needed for his prior ankle sprains. The patient's goal is to return to playing soccer without any pain, and he wants to prevent any more ankle sprains from reoccurring. So the patient lives at home with his parents and 2 younger sisters. He lives in a 2-story colonial-style house with 4 steps to enter into the house with a railing on the left side. His bedroom and bathroom are on the 2nd floor with 12 steps and a railing on the left side. So some of the positive exam findings include swelling on the anterior and lateral aspect of the ankle with 2 centimeters greater on the right. Passive dorsiflexion and passive plantar flexion range of motion was limited and painful. Specifically, dorsiflexion range of motion with the knee extended and bent was 5 degrees on the right, secondary to pain. And passive plantar flexion range of motion was 20 degrees on the right, secondary to pain. Passive range of motion on the left, however, wasn't within normal limits, with 20 degrees of dorsiflexion and 45 degrees of plantar flexion. The patient was unable to take resistance for the resisted dorsiflexion, plantar flexion, eversion, and inversion tests due to swelling and pain. Therefore, accurate MMT grading of the surrounding musculature cannot be performed at this time due to pain. An anterior talofibular stress test was performed, and it was positive with pain. The audible ankle rules test was performed, and this was negative, which helped to rule out a potential fracture. In terms of palpation, there was swelling, as I mentioned before. There was mild warmth and tenderness on the anterior talofibular ligament. In terms of gait, the patient was able to ambulate 20 feet independently with an antalgic gait and decreased step length on the left. So overall, the patient is healthy and has no significant past medical history. So my PT diagnosis is ankle stability and movement coordination impairments. The pathoanatomical diagnosis is an acute lateral ankle sprain. So my first priority for treatment will be to decrease pain and swelling in order to improve ankle range of motion. This is important to focus on first because it will help him to return to a normal gait pattern. The next priority will be to improve range of motion, especially dorsiflexion, so the patient can maneuver stairs and move around his house. Once swelling and pain have subsided and the patient has gained normal range of motion, it will be important to reassess their strength of the surrounding ankle musculature. This is important in determining if certain muscles were weak and could have been a contributing factor for spraining his ankle. Improving the patient's strength and stability will also help to prevent him from re-spraining his ankle in the future. As of right now, I don't have any questions for you regarding my patient at this time, but now I'm going to present you with my plan. So since the patient is in the acute phase, Price MEM should be followed. Treatment will start with soft tissue massage with effleurage strokes towards the patient's heart to promote tissue healing and decrease swelling. Deep friction massage should also be performed on the anterior talofibular ligament to help break up the swelling. This should be performed 5 minutes every day, followed by active range of motion. And some of the active range of motion exercises that should be incorporated include ankle pumps, alphabet exercises, marble pickups, and towel curls. An Achilles tendon stretch should also be performed to promote dorsiflexion range of motion. This should be performed on the table with the leg elevated, which will also help with reducing swelling. Once these exercises are done, ice and a compression wrap should be applied to help control the swelling. The patient should also be given crutches to help with the antalgic gait and pain, and he should be instructed to avoid any pain-provoking activities. Since the second priority is to gain range of motion, once the swelling and pain is decreased, I want to focus on a posterior talocrural joint mob and rear foot distraction thrust to increase dorsiflexion for stairs and walking. And stretches into dorsiflexion should also be utilized to help increase this range of motion. And lastly, Since the third priority is to gain strength and stability, it is important to strengthen the surrounding ankle muscles with manual resistance or band exercises. This can then be progressed to heel raises and heel walks in the weight-bearing status. And lastly, single limb stance progression and balance boards should be used to increase balance and stability of the ankle to minimize the risk for re-injury.